Thank you, sir, for your kind introduction. Thank you. Good afternoon. At the outset, I'll thank the RSSDI 2021 for giving me this opportunity, particularly Dr. Bansi Sabu and Dr. Sanjay Agarwal. So my talk would be on prediabetes, diabetes, and cardiovascular disease. First and foremost, I apologize for my bad throat, so do excuse me. So obviously, the talk will revolve around the status of the glycemia and its impact on the cardiovascular risk. So this is the natural history of type 2 diabetes, and we all are aware that the insulin resistance occurs very early in the disease and it progresses as the duration of diabetes increases. But most importantly is the macrovascular complications. This is the dreaded complication which occurs much earlier in the disease rather at the pre-diabetic stage, and we are all aware of it. And this is an important slide because this gives you an insight into the status or into the prevalence of the pre-diabetes in our population. So this is a US population, and if you see, out of 104 million glycemic abnormality, population with glycemic abnormality, about 79 million were pre-diabetic. That's a huge burden. Even just about, I think simultaneously the presidential oration was going on, and Dr. Bansi Sabu rightly said that 50% of the patients, or more than 50, are pre-diabetic and 50% are undiagnosed. So this is a huge burden, I would say, in our society. So that's becomes very important. It's very difficult to go for universal screening. So you have to screen at-risk population. As Dr. Lilia has already showed us which are the risk population in the pregnant group. So these are the various risk factors where the selection should be made and screening should be done. So every one of us are aware of it. The age more than 45, though it doesn't count in India. Family history of type 2 diabetes, CVD, overweight, sedentary lifestyle, member of some ethnic groups, dyslipidemia, and impaired glucose tolerance or impaired fasting glucose with metabolic syndrome, PCOS, acanthosis nigricans, and NAFLD, hypertension, gestational diabetes, delivery of a baby weighing more than 4 kgs, antipsychotic therapy, and chronic glucocorticoid exposure. So all these are important. If a person is in normal range, he or she should be evaluated every 3 years, along with always consider annual screening for this individual with 2 or more risk factors. And these are the diagnostic criteria. We need not go into it. Every one of us are aware of which are pre-diabetic and which are diabetes, how to diagnose. Most important, A1C should be used only for screening pre-diabetes. The diagnosis of pre-diabetes is never made on A1C. It should be done on the glucose testing, whether you're going for a fasting or a prandial or a OGTT. So that's important because it has own problems with HbA1c in different groups. You might have a faulty error HbA1c. Now let's go into the evidence for current cardiovascular disease, the prevention guidelines, the pre-diabetic conditions. Now this is the diagnostic criteria. Now this is important because this is the underlying problem in prediabetes, and the crux of the whole issue is endothelial dysfunction. Endothelial dysfunction, oxidative stress, pro-inflammatory status, and these are all going to lead into the macrovascular disorder which is associated with prediabetes, that is CVD, stroke, and peripheral vascular disease. Along with that, in our population, particularly the Southeast Asian population, we have comorbid conditions which are very prevalent, or the other metabolic dysregulation which are very common whenever a patient is diagnosed as a pre-diabetic or diabetic, whether it is a hypertension, dyslipidemia, obesity. So all of these are very prevalent, so importance is modification of these risk factors is essential when managing a pre-diabetes. And this is a known fact, but it's important that the risk of diabetes increases with increasing HbA1c. If the patient has been in the quartile 5 or less than 5 to 5.5, probably they do well and they do hardly progress to diabetes mellitus. But as the HbA1c increases from 5.5 to 6 or 6.2, 6.4, the incidence of diabetes increases in this group of population. So it's very important that as and when you are measuring the HbA1c, that gives you an idea. So screening is important to screen the patient for pre-diabetes, and thereafter other modalities need to be taken into consideration while diagnosing the prediabetes. So if you look at this particular meta-analysis of 18 clinical trials evaluating the risk of CV disease among patients with impaired fasting glucose and impaired glucose tolerance, and you see in both the conditions, there is an increase in the risk of CV disease. These are the various studies, and the meta-analysis clear-cut pointed towards increase in CV disease in prediabetes. And obviously, prediabetes not progressing to diabetes. There are for that lot of studies were done, and the benefits of different modalities or management tools were undertaken, particularly the lifestyle, the Finnish diabetes prevention trial. This was the Japanese trial, and then with the Indian trial with Ramchandran, all have shown that the lifestyle modification is the most correct way of managing a patient of prediabetes. There is no incremental benefit if you add on to the lifestyle with metformin. This is what Ramchandran et al. Showed, and lifestyle modification should be the idea. But in spite of lifestyle modification, if we really have to go for anti-glycemic medication, we have few other studies that stop NIDDM with a carbos, which really showed benefits. And the DREAM trial, the plus point was that with rosiglitazone, there was a reduction in the incidence of diabetes, but along with that, death reduction was also seen. So along with that, if we go to the ACT-NOW trial, obviously pioglitazone scores over here, and it definitely has some role in prediabetes, wherever we feel that some kind of anti-glycemic management has to be given in that group of population. So what could be the pathogens of increased CVD in diabetes? See, basically, if you have gone through a meta-analysis recently published in BMJ 2020 for prediabetes, which was done by Yang et al. Or Zhang et al., they clearly had gone a meta-analysis of 129 studies, and their clear-cut conclusion has been that prediabetes definitely lead to CV risk, CV mortality, and all kinds of CV mortality, basically. So considering that, and now what could be the pathogenesis? The overall, what I said, the basic problem is with endothelial dysfunction, and on top of that, if you have the metabolic factors and hypertension like dyslipidemia and hypertension, probably they will increase the incidence of CVD in diabetes. So increased endothelial dysfunction, increased inflammation, increased prothrombotic state, and increased oxidation all will lead to increase in CVD in diabetes. And this is a known fact that patients of diabetes do not die of glycemia. The mortality is because of the CV events, and that comprises of about 2/3 of the population of diabetes. So that becomes more important, that we need to take care, or we need to assess the CV risk of an individual, whether it's in pre-diabetic state or diabetes, and try to address that issue. So atherosclerotic complications, these are responsible for 80% mortality among the diabetes. And most of them are obviously coronary artery disease. And hospitalization, also the major contributor is atherosclerotic CVD. The 50% of the patients with type 2 diabetes have pre-existing CAD. If an analysis was made for, say, about a coronary artery disease patient, and if you do a OGTT in those patients, you'll be surprised to see that those patients who had almost like no known history of dysglycemia, they turn out to be dysglycemic on OGTT in almost 2/3 of the patients. So that was done by Lindell et al., and that was person in metabolics. So that is the importance, that we are not even aware of the patient's glycemic status. And that is the whole idea should be to recognize which are the patients or which are the individual we need to be screened, so that early diagnosis and proper management is imparted to the patient. So this is the mechanism. See, diabetes means you are at a subclinical atherosclerotic label. And these are basically contributed by the hyperglycemia per se, which is increased AG and increased oxidative stress. To add on to it is obviously insulin resistance, inflammation, increased inflammatory markers, and dyslipidemia and increased thrombosis. When the disease progresses, these leads to the events. So basically, diabetes per se is also having a subclinical atherosclerotic milieu, and on top of it, if you are unable to control the glycemia, probably you'll end up with atherosclerotic clinical events. Insulin resistance obviously is a link between CVD and the type 2 diabetes, is an independent predictor of CVD, closely linked to a number of CVD risk factors, and they develop much earlier than the diabetes. And obviously that led to NCEP recognized type 2 diabetes as a coronary heart disease risk equivalent, but we don't use the terminology anymore because there's a lot of controversy around it, and because we are getting lots of younger patient with type 2 diabetes, and as a result, we cannot use this particular terminology at present. So if we look at the insulin resistance, which is basically linked to the cardiovascular risk factors, again, the whole issue is endothelial dysfunction and vascular inflammation. On top of that, if you add hypertension and dyslipidemia, obviously that leads to the atherosclerotic and CVD. This is how insulin resistance is linked. And it is this Verona diabetes complication study has clearly showed that insulin resistance is an independent predictor of CVD in type 2 diabetes. Now, once you are aware that these two elements in glycemia, the prediabetes and diabetes, they are linked to the cardiovascular risk, then you need to categorize that, and this has become in the ESC 2019 that they can be categorized into three risk categories. The very high risk, that is patients with diabetes and established CVD, or having target organ damage, or having 3 or major risk factors, or if there is an early onset type 1 diabetes of longer duration, more than 20. So they fall into the very high risk categories. And the high risk is the one who have a DM duration of more than 10 years without any target organs, but having any other additional risk factor. The moderate risk are the ones. Say previously there was an issue with the moderate risk or no risk. Now they have clearly mentioned the moderate risk population, those who are below 35 years type 1 diabetes or type 2 diabetes less than 50 years with DM duration of less than 10 years without other risk factors. The fourth group, which is the no risk group, obviously those are the one that has led to the whole issue of coronary artery equivalent, risk equivalent, becoming a question mark, because there they say the type 2 diabetes less than 35 years with no other risk may not fall into that particular category. So that is one thing which you all can give an idea on. So, but we need to think about that as well. This was the East-West study where it has clearly showed that patient with diabetes and no CSD experience has a similar rate of MI and as patient without DM but with CSD. So this again clearly showed that the risk of MI in diabetes is quite high. And similarly, this particular slide clearly showed that diabetes with prior MI has a high risk of CSD risk, and the risk of cardiovascular events and death. When you have a combo of CVD plus diabetes in all, whether it is CSD mortality, CVD mortality, or total mortality, it is of importance. So basically, a combo of CVD plus diabetes is notorious, and it increases the mortality. Okay. Meta-analysis of 102 clinical trials evaluating the risk of cardiovascular events due to diabetes mellitus has showed significant increase in the risk of adverse cardiovascular events. And this is important. We still go back to the UKPDS, and we all are aware of the 10-year follow-up of intensive glucose control, and we have seen the emergent risk reduction of myocardial infarction and death of any cause during those 10 years. So it's become important. The glycemic legacy stays, and that leads to the decrease in the myocardial infarction and death. Obviously, it has an impact on the microvascular. We are not going into that. So what are the recommendations for glycemic control in individuals with diabetes? One should be aware that it has to be individualized. In order to reduce the microvascular complication, the HbA1c has to be brought down less than 7%. And even for prevention of macrovascular complication in individual diabetes, the HbA1c target of less than 7% is important. Avoidance of hypoglycemia is recommended. That is a class 1 level C evidence, and the use of structured self-monitoring or CGM is also required to facilitate a good glycemic control. So these are the trials which actually made a question mark on the intensive glycemic control that was advanced in ACCORD. And the ACCORD, but if you look into the recent analysis of ACCORD trial, it showed that death related to unsuccessful intensive therapy where A1C remained high. So that was the major contributor to the death, and not to the hypoglycemia per se. But in both acquired and advanced, those with macrovascular disease at baseline had an actual benefit in primary endpoints. So intensive glycemic control do have an important role to play, and just few slides, please. So this obviously Wikipedia is also shown, and this whenever you're planning out that these patients are for CV, they have a CV risk, then you have to assess them. And these are the various modalities through which you can assess the CV risk. There is controversy, there will be controversy, but this is the 2019 recommendation. The class 1 is obviously resting ECG is recommended in patients with diabetes, mellitus with hypertension suspected CVD. The class 2A is carotid or femoral ultrasound should be considered for plaque detection as a CV risk modifier. Screening for CAD with coronary CT angio and functioning imaging may be considered. CAC scoring may be considered. ABI may be considered. These are class 2B. And carotid ultrasound intima media thickness or CV risk is not recommended. It's class 3 actually. So how do you manage? You manage the risk factors. Cessation smoking is important. Of smoking is important. You control the blood pressure, blood glucose, and the lipid control. Weight loss is important. Now use of low dose aspirin for secondary prevention of CV events in patients with existing CVD. Primary prevention, those who have a CV risk of more than 10% at 10 years. And then measure the coronary artery calcification or use coronary imaging to determine whether glucose, lipid, or blood pressure control efforts should be intensified or not. Statin use, obviously use a statin regardless of the LDL labels with diabetes who meet the following criteria: more than 40 years of age or having one or more risk, ASCVD risk factor like hypertension, family history, or low HDL-C smoking. And these are the various outcome trials. I'm not going to details with the newer glucose, which has basically, again, if you use these trials as a modality, probably that clearly proves that diabetes mellitus is a cardiovascular risk. So near treatment algorithm, if you look at the pre-diabetes algorithm, obviously CVD risk factors need to be taken into control. The weight loss therapy need to be initiated, and one need to halt the progression to the overt diabetes. Anti-glycemic therapy can be initiated if you feel like. Then the low risk medication, obviously metformin, acarbose, and always consider with caution thiazolidine and GLP-1, but they have shown certain results in pre-diabetic stage. And this is the ADA ESC guidelines, focus on reducing the risk of CV death. So obviously glucose control is one, as already spoken about, that individualization HbA1c target need to be addressed. The blood pressure lowering is important, and you need to keep that in targets. LDL cholesterol lowering, individualized diet and lifestyle. So these are the modalities through which focuses on reducing the risk of CV death in patients with type 2 diabetes. Thank you. Thank you.